Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Melanoma Matters. My name's James Larkin.
I'm Sapna Patel.
And today we're going to have our second neoadjuvant discussion following on from OPAS and Neo last time. But before we do that, Sapna, maybe another art type question for you as a sort of opener. So this is going to be maybe music. So
Okay.
apart from Taylor Swift, maybe, although you can talk about Taylor Swift if you want, who's your favourite recording artist or musician?
That's a really good question. I do like Taylor Swift, and I was really late to that game. I just, found her mature stuff less than a year ago. So I've been listening to some Tortured Poets. I'm a Post Malone. I like Post Malone. I really started listening to him around 2018 or so, and he's a fellow Texan originally. There is a song that's out right now that I just have on repeat. I went down a wormhole of probably watching the Instagram clips of it yesterday for an hour. It's Morgan Wallen, country star Morgan Wallen and Post Malone. It's so good. It's so good. That's my, yeah.
Do you like any music that came out before the year 2000?
So I can tell you my first concert that I went to. My first concert in Dallas, Texas was 1995, and it was Oasis. They had just come out with Wonderwall, and it was Liam and Noel Gallagher, in a small venue in Dallas. It was incredible. And then after that, I saw Depeche Mode a few times throughout, I think, college and med school. Yeah, those are my old ones. Erasure.
Right then, so segue into Prado, which we thought was the next important study we should talk about over OPAS and Neo. So tell us about the background, and I guess tell us at least to start with why it's important.
Well, it's just another beautiful study from Christian Blank and Georgina Long and Richard Scolyer and Bart from the Netherlands and Australia. Just a great study showing how you can personalize an approach. So on the heels of OPAS and Neo, they found an optimal regimen of combination immunotherapy to give in the preoperative setting. And they said, well, what if we then look at how each patient responds to this and personalize what we do next? So the P and the R in Prado stand for personalized response-driven approach. And so they basically took 99 patients with clinical stage 3 disease, so involved lymph nodes. They gave them this optimal dose of Ipi-Nivo, so Ipi 1 milligram per kilogram, Nivo 3 milligrams per kilogram. They gave it for 2 cycles. And then after 2 cycles, they had removed what they call the index lymph node. And we'll come back and talk about index lymph node in a second. They then did surgery solely on that index lymph node and categorized the pathological response in that lymph node as either major, partial, or non-response. Major being complete eradication of tumor or 10% or less viable tumor, partial being greater than 10% to 50% viable tumor, and then non-response being anything more than 50% viable tumor in that index lymph node. Based on that categorization, the major path response patients were finished. No more surgery, no adjuvant therapy, standard follow-ups, and they moved the follow-up to a 3-monthly interval or a 12-weekly, as it were. Partial responses, they took those patients and completed the surgery. So they ended up with the therapeutic lymph node dissection. But then because that initial response was so strong in the index lymph node, 10 to 50% viable tumor, so less than half of the specimen viable tumor, they then eliminated further systemic therapy. They just cleaned it up with surgery. And the non-responders, they did everything. They did a full surgery and they did adjuvant therapy. And that adjuvant therapy could be single agent PD-1 nivolumab or targeted therapy with the option of radiation if necessary. So that study is really important. Maybe I'll just make a quick word about index lymph node. You might ask yourself the question, why can we go straight to just removing a single lymph node, the index node, and not do a full surgery? And this group again had looked at a series retrospectively from Opasin, Opasin Neo, and perhaps some other small series where they looked at the representativeness of it, what they would call the index lymph node, historically the largest lymph node, versus the entire specimen. So they gave these pathologists, Bart and Richard, they gave them essentially the index lymph node, and then they gave them the full surgical specimen. The pathologists were blinded, and they basically read the index lymph node for a response. Then they read the entire specimen. And when you put these two together, there was a very high concordance rate. I mean, in the high 80s, that the index lymph node told you what was happening in the entire specimen. A few discordances, and some of those discordances went in favor of the index lymph node kind of undercalling the response. Index lymph node might say, oh, there was a bit of necrosis, but actually in the full specimen, there was quite a bit of necrosis. And then there are a couple of cases in the inverse where the index lymph node might have overcalled it. Nevertheless, that's to say pretty high concordance rate. So what's happening in what we call the index lymph node is fairly representative. And with another caveat there that we have not defined as a field what is the index lymph node. So is it the largest lymph node? Is it the most superficial? So it would be the first one in a therapeutic dissection. Is it just the easiest one to mark? Should the surgeon tell you which one is the index? Should the radiologist be telling you? Is it multidisciplinary? They chose historically the largest lymph node, which is probably a really reasonable place to start. And then I think this opens the door for discussion. So that's a lot of talking.
Yeah. Yeah, well, then, so I mean, quite a lot of different things happened in this study to 100 patients. So that's maybe one comment to make. So am I understanding correctly that if you had a complete response on pathology, then you would have only had the index lymph node removed? So then if you had had more than one involved lymph node, then the other lymph nodes would remain in situ afterwards, and then those patients didn't get any further systemic treatment. So we call that cherry picking. I don't know if you have that in the US or not. Cherry picking lymph nodes. Is that a yes or a no?
Isn't that a George Washington term, like cherry picking?
I don't know what it means in that context, but we use it to denote it, with lymph node surgery when you're doing less than what would be considered, if you like, the standard of care. So if you're not, for whatever reason, doing a therapeutic node dissection and you're just taking out one or two or the palpable ones or so, we call that cherry picking. But maybe that's a British thing. Anyway, so what about those patients then? I'm specifically asking about that group of patients. Do we know anything about what happened to them subsequently?
Yes, that's a super point. So in a major pathologic response, the hypothesis was you've already given such a strong jumpstart to the immune system that, runs the day here, right? This will give you the long-lasting benefit that you need as a patient. And so the hypothesis was that in major pathologic response patients, in the first 24 months, there would be no recurrences or distant metastasis. They've had an excellent response. 90% of their viable tumor is eliminated. So they are finished. Now, you made a point, you're taking out a single lymph node. What if you had multiple lymph nodes involved? Still, the hypothesis holds, right? That in situ immune system that got generated is still there. You didn't remove that immune system necessarily. You just removed the ones attached to the tumor. So that should probably continue to keep going. But is 2 cycles enough to generate that long-term benefit? I mean, you probably know better than anybody. One of the biggest questions is, when does somebody generate a memory response to their tumor? How many doses does it take? How much duration of therapy? And it's going to be different for every patient. Probably 1 and 2 doses is not quite enough. It gives you a good batch of effector T cells, but is it giving you the memory T cells? So that's the biologic hypothesis. The short answer is there were 4 patients who had recurrences in that major pathologic response group. Now, there were a bunch of patients who fared really, really well. And I think if you want hard numbers here, it looked like 60 patients got a major pathologic response. 4 had recurrences in those first 2 years. So that's low. Agree, that's pretty low. But it's still important. If you're one of those 4 patients, you got an upfront therapy, you got a minimal surgery, nothing more, you were feeling pretty confident that this melanoma was an episode behind you, and now all of a sudden you've had a recurrence. And worse than that, if you've had a distant metastasis. So 4 patients with a recurrence, when they took a deep dive, these 4 patients all had 2 clinically positive lymph nodes on imaging before they started the treatment. So that led to some hypothesis. Well, if you have more than one clinically positive lymph node, is index lymph node appropriate? So then they went back and looked how many patients had more than one clinically apparent lymph node. Well, they had a good number. I'll pull the numbers at some point, but they had a fair number of patients with more than one at the beginning. Maybe, I don't remember how many of these are, a handful or 2 handfuls. And a small portion of these, 4 of these patients recurred, right? So then do you need to do more surgery in patients with more than one lymph node at the beginning just to help this low number of patients who might have a recurrence? Is that their biology speaking? That's questionable. The authors are concluding you can eliminate therapeutic lymph node dissections in patients with a major partial response because the majority of these patients do well. But what of these 4 patients who didn't do well? So I think right now that's considered fairly controversial in the field, and still the surgery for clinical lymph node involvement, whether it's single or multiple, the standard surgery would be a therapeutic lymph node dissection. But I think the study really tells you you can really get to a point where you can do less surgery if you can figure out how to identify these patients who might be at risk of recurrence despite a positive outcome. I don't know if I fully answered your question there, but
No, I think you did, and that's exactly the crux of it, isn't it? So then my next sort of set of questions, or big question, is going to be about pathological response, and something I always wonder about is, how are we setting these bars? How are we drawing these lines, making these categories? Is it because someone thought it was the right thing to do? Or is the biology shouting out to us, the pathologists, that these are groups that are obviously segregating? Because just imagine, for the sake of me being difficult anyway, that you move the bars around a little bit, the percentages, and then the patients change categories. That could actually have a major impact on how we think about these different groups. So if you like, how rigid and how based in biology. I mean, it's like, listen, it's easy to understand with a complete response, right? And it's the same for imaging. That's obvious. I think it's quite easy to understand no response at all as well. That's fairly obvious. But it's all these bits in the middle. Are there really categorical cutoffs, or are there a load of shades of grey in here? And again, can I ask you to say something about sampling? Because this worries me as well.
yeah.
Not in the study necessarily as well, but one of my obsessions is sort of tumor heterogeneity, actually, and in many cases, depending on how you analyze things, the more you look, the more you see, and so how finely should these tumors be cut off, right? So that, anyway, there's a load of stuff to be thinking about there.
I like those questions. This idea of how rigid are the cutoffs versus how based in biology, we can go back to the breast cancer days and look at things like estrogen receptor expression and the variability, what one pathologist calls 1% and another calls 2%. This makes all the difference, right? Less than 1%, 1%, you're now basically changing whether you would offer somebody estrogen-based therapy, anti-estrogen-based therapy based on this, and it can be subjective. So ultimately, I guess maybe leaping forward with your question, would AI ever be able to do what maybe the human eye is too subjective to be able to do? I don't know. The International Neoadjuvant Melanoma Consortium wrote a white paper on this pathologic response, and they used multiple pathologists to try to decide on concordance. In other words, can we agree what complete pathologic response is? Can we agree what major is? Basically, what 10% viable tumor looks like. Now, is that based in biology is challenging because that obviously presumes that the pathologist ultimately knows the long-term outcome of these patients and can say, these patients who did very well, what was so special about those tissues? The International Neoadjuvant Melanoma Consortium put a lot of work in this, and they obviously supplied the medical oncologists, the statisticians, everybody who evaluated this, the pathologists, with information. But you and I both know that that was a group of trials that were done in small numbers at specific centers with different regimens, so different exposure to immunotherapy, which maybe makes the point that despite the regimen and the duration, pathologists can agree on what 10% viable tumor is. Sure, we can agree. But if we just slid that bar down to 5% and called that a major, or slid it up to 20% and called that a major, are we lumping together a similar group of patients? And ultimately, so maybe that's the first part of it. Maybe I should say I don't know, because I don't know how, these things were fully derived, if it was fully based in biology. I'd like to believe yes, but your point is very well taken. As you know from Checkmate 067, you can call something PD-L1 at 1% or 5%, and you can get some different groups here and maybe pick out different, cohorts of patients. Similar can be done with pathologic response just by moving around what we call partial, major, et cetera. And it should be noted that this definition is not uniform across tumor types. So that's one thing. Did you want to say something there?
Yeah, no, I mean, I think the last point you just made is a really important point as well. I mean, I only treat two types of cancer, but this assumption that you can transpose things, from different cancers one to another, or even different treatment modalities, I think you need to be quite cautious. I mean, I like the kind of AI idea because it's kind of, everyone likes to talk about AI, and I suppose just kind of thinking kind of completely outside this, the hard endpoint we're looking for is freedom from melanoma recurrence. We can all agree on that. So it's almost as if in a well annotated data set, you would want to, if you could, in due course, work back from that, and then to some extent agnostically reinterrogate the pathology samples. That would be, I don't know if anyone's trying to do that or it's possible, but very, very interesting exercise, because there might be some stuff in there that kind of we don't even know about, we hadn't thought about. But that still comes back to sampling. And I want to ask you about sampling. Okay, so let's say it's a lymph node. You can slice it in half. That's the simplest thing you can do to a lymph node after you've resected. And then you could, look at a section from the middle of the lymph node. Okay, so that's the one end of the spectrum. The other end of the spectrum, you could slice it, you could salami slice it, across multiple axes, actually, if you think about it. And then you could really go down and you could look at hundreds or maybe even thousands of samples, even get down to the cellular level. So I've got two questions here, really. One is that presumably, again, I'm obsessed about the sweet spot. It's all I ever talk about, isn't it? Is there, do you think, a sweet spot for sampling whereby if you keep slicing further, you're topped out? There's a ceiling effect. You're not going to get any further useful information. That's question one. Question two is, what about pathologists in the real world outside big academic centres that we work at? Because there have to be some trade-offs there for time. It's all very well saying, we did this, and this, but now we want you to double or treble your workload, and they're busy doing loads of other things. So what do you think?
Yeah, that's a great question. So sampling is an issue. So can you top out by doing that salami slicing? And I think we just need only look at our sentinel lymph node pathology literature. Victor Prado reminds me of this often, is that back when sentinel lymph nodes were being removed, you're looking for microscopic melanoma in that lymph node. You couldn't clinically see it. So they couldn't just bivalve the tumor. I mean, they could, that's how they started. But to be sure, they thin sliced those lymph nodes. To be sure, does thin slicing pick up more than doing what we call gross tissuing, which, by the way, Ryan Sullivan often tells me that there's grossing, gross, and disgusting. He doesn't understand how gross is a synonym for disgusting, and grossing, however, is a technique. So anyway, so that grossing, turns out that's what you need to do for sentinel lymph nodes. You don't have to thin slice anymore, but they had to go and do validation on that. So they would do the grossing, then they would go back and do thin slicing and see if they would catch more with the thin slice. Turns out, fortunately, you didn't need to do it, but he remembers woefully those days where they had to go back and look at all these extra slices. So, what the International Neoadjuvant Melanoma Consortium is saying is thin slicing is really important. Thin slicing is important because you need to assess the entire tumor bed, which has now had some treatment effect, which is going to be not just apparent on bivalving or having that having that lymph node sample. So that thin slicing, as you can imagine, takes time. It also, we need to be sure that it informs the outcome so that it is actually worth the general pathologist's time to do it. And I think we know in these academic centers, it's so informative on an individual patient level. So you can very clearly, comfortably tell an individual patient, I'm very happy with this response. This response looks favorable to me. It basically looks favorable all the way unless you have a 100% viable tumor. By the way, if you have a pathologic non-response, are we sure that's unfavorable because you still got exposure to neoadjuvant therapy? You still got a boost, like a jump-started immune system. So unfavorable compared to a patient who gets a complete response, sure, but we should not be comparing patients to each other. Favorable compared to the opposite approach, which would have been to take out your tumor in the first place and give you adjuvant. No, you probably still had a favorable approach. I said no, but I should have said yes there. Anyway, the point being, so that's one thing is making sure we're clear that on an individual patient level, you get a lot of information about this. But how does this impact a hazard ratio for a group of patients? We have yet to have a trial tell us that. Now, maybe that's forthcoming and we'll get some information. The other kind of key point is there's a chain of custody here. So the sample comes out of the body. The surgeon needs to know from the medical oncologist that you gave that patient immunotherapy for a couple of reasons. One, they might need to do some preoperative, adrenal dosing of steroids if there's some, or check for adrenal insufficiency if there is some risk that the regimen made them adrenally insufficient, because these patients can go horribly badly postoperatively if they're adrenally insufficient or bordering on it. And two, because that surgeon has to mark it that way so that the grossing technician now thin slices and doesn't just have the tumor. Because as you and I both know, after a tumor is bisected and basically stamped on a slide, and then it's sent to the pathologist, the remainder of that tumor tissue is often chucked pretty shortly thereafter. It's not kept in perpetuity for years and years and years. If the pathologist says no viable tumor, those end parts of the lymph node that were not thin sliced are not saved necessarily for too much longer. So you can't go back a month or 6 months later and say, oh, pull that out of the freezer. I want to look at that again. So thin slicing upfront is very important, which means informing the grossing technician, which means informing the pathologist. Don't just tell me if there's tumor or no tumor. Now read it to me like a neoadjuvant specimen. Define the tumor bed. Tell me if there's residual tumor. Tell me if there's necrosis, fibrosis, ideally hyalinized fibrosis, and pigmented macrophages, and do that math. And I guess the reason AI could be so intriguing, and we are digitizing samples, the slides from all these neoadjuvant trials now moving forward, is that perhaps we're focusing too much on viable tumor or dead tumor when there's some other marker in that slide that an immune response has been generated, and that could correlate with survival. So maybe we're focusing on the tumor, but as Jim Allison always says, immunotherapy doesn't even look at the tumor. It's working on these T cells in the immune system. So maybe we're looking at the wrong part of the slide, but not a pathologist, so I don't want to, let's just put a real clear underline on this. Pathologic response is hugely important. It is one of the tools that we have right now in this disease, but have we scaled it yet, I think is the real question.
Yeah, that's great. I'm sure we can all agree that. And then maybe that's quite a good way to sort of wrap up. Is there anything that we haven't said about Prado that you think we should say?
Oh yeah, good question. Prado was a global study. I think that's always important to say because it does tell us now we're getting to be able to scale some of this treatment of patients. And in these countries where it was done, there was a central pathologist looking at it, which is great to do. But again, you'd love to know, how does that track back with the institutional pathologist at all of these places as you start to expand it beyond these fancy centers? Is the institutional pathologist and the central pathologist in agreement? So there's one other point to be made, and it's in the partial responders in Prado. So in the partial responders, this is a group of patients who have somewhere between 10 and 50% viable tumor in their specimen. So by all accounts, they're doing really well. That couple of doses has jump-started some type of an immune response. It's just not fully eradicated their tumor or done it in a major way, if you will. That's okay. We still think that's favorable. And that group of patients received surgery only and no adjuvant therapy. And surprisingly, that group of patients, if you look at the curves, did not do as well from a recurrence-free, distant metastasis-free survival as one would have presumed, despite having that jump-started immune system. In some parts of the curve, as you get to 2 years, they're actually the lowest performing patients. And that may speak to the need for actual adjuvant therapy in this group of patients. So they had some sort of jump-started immune response, but you still need adjuvant therapy to mop up whatever is sitting behind microscopically. How much adjuvant therapy, I don't think we know. What regimen, I don't think we know. But that partial response patients probably need more than just surgery. And, credit to these investigators. They took that into consideration when they discussed when they designed their next trial, which is a major Easter egg for those of us in the field, because we know a big trial report is coming.
Okay, thank you very much indeed.
Thanks.